Welcome along once again. We are going to, I just wanted to thank Philips again and acknowledge Philips for their generous support that help us be able to bring these sessions to you. Once again, I've been practicing with their little machine, and I've got a couple of new ones that I'm going to look at tomorrow. But the Lumify has provided some normal cases again for our chat this week. So today's topics, we're going to look at how to measure the CBD. I'm going to just walk through how I go about reviewing images and the things that I'm taking into consideration. And then we've got a few pictures that you guys can get in on the action and give me your thoughts on what you think can be done to improve them. So we're going to start with CBD measurement. This is just for you, Jono. So this is interesting. This common bile duct is normal when it has a diameter of 6 millimeters or less. It's got a range of 4 to 8 millimeters. So, and that's the extrahepatic portion. The bile duct will increase with age, and our golden rule, of what I learned way back in the dark ages, was for every decade of life add an extra mil after the age of 60. So a 70-year-old would have a 7 millimeter upper limit, 90-year-old a 9 millimeter, but anything up to 10 millimeters is considered normal in the elderly. So the common bile duct is formed where the common hepatic duct and the cystic duct join. So we're looking at this kind of segment all the way to the pancreas. And it's interesting because as I was looking for pictures for the talk to illustrate, to help me sort of map out how I go about scanning it, every single picture I found presented the gallbladder and the bile duct in this orientation. And I'm thinking through the way that I scanned and what angle my hand is at, and where the probe is sitting on the body. And for the life of me, I couldn't marry up why this looked so vertical, because when I finally get to the common bile duct view, I'm almost transverse on the patient. And so I was trying to find an image that would illustrate that concept so that I could demonstrate the anatomy the way we see it on the ultrasound, and just all the textbook anatomy, it just didn't do it. But it's interesting because the textbook anatomy looks at it from the front on, and when we're taking a transverse cut, or when we're looking at the bile duct, we're kind of looking at the bile duct as if we're looking from the bottom up. And it was only when I got my trusty liver model out of the anatomical model here and looked at it from underneath that I understood the orientation of bile duct better again. And I have to say the trusty liver anatomical model here also helped me understand how it is that gallstones roll upwards when you roll the patient on their side. It's not necessarily made the common mistake of thinking that closer to the probe is up, whereas it's not. It's closer to the probe is superficial. So when I look at this liver model here, I can start to figure out where things sit in three-dimensional space, and certainly looking at the bile duct from underneath now makes sense because it's in a much more horizontal position. So if you are getting stuck on your where things are sitting, or it's not making sense, you can't quite get the view, I really do recommend going back to the old models and just having a look and understanding how the slice is happening to get your views. So essentially what I'm doing is starting midline, transversing to where I see the portal vein exit the liver, or enter the liver really. So where it goes from abdomen, and as it enters the liver there, I then hold the top of my probe still and pretty much pivot the bottom bit until I lengthen out the portal vein and the bile duct. And then I tilt the probe a little bit, just a squeak towards the patient's head. So we slide from the patient's midline rotate the probe, and then tilt the probe up ever so slightly. So some scanning tips here. Your biggest friend when you're looking at the bile duct is the cine button. Now, just remember that when you push the freeze, I think this is one of the most underutilized buttons on the machine. When you push the freeze button, the image or the system will store in its system, in the short-term memory, it'll store anything up to 200, 255 frames, depending on which machine you're using. And so when you push freeze, you can then rewind. You might have captured or gone quickly past the bile duct as you're scanning. And when you push freeze, you can kind of rewind the machine with the cine loop function and fast forward until you get to just the frame that you need to look at. So don't forget to use the cine loop button. It's one of your best friends, especially for the bile duct. The other big tip that I'd say is straight up, don't muck around with it. Get your patient on their left side as soon as you can. This just lets the liver drop out from behind the ribs just enough so that we can get a slightly better window on it. I also get the patient to take a big breath in and hold their breath. This can this pushes the liver down from out behind the rib cage. And when all else fails, try an intercostal approach. Sometimes it can work, sometimes it doesn't even help at all, but it's always worth giving it a crack. So here's a normal bile duct. We have the portal vein here, the hepatic artery in cross section. It's coming out towards us out of the TV. And then you see the common bile duct running parallel there with the portal vein. And we want to measure it after the hepatic artery. That's our landmark. The common hepatic duct, or the common bile duct is defined or starts, and where we need to measure is after the hepatic artery here. And this one's a particularly good example. Over here, we can see the head of the pancreas. So you can see the whole length of that bile duct there, which is a real treat. They're never always that pretty. We've got portal vein, hepatic artery, common bile duct. So again, my technique is I like to have a landmark or a home base for any image. So I start in the patient's midline. We can identify the aorta, and then I follow the costal margin sweeping to the patient's right side. I follow the costal margin down slightly until I see where the portal vein is just entering the liver. Once I get to that point, I'm rotating the probe anti-clockwise to lengthen out the portal vein. And once the portal vein's lengthened out, I can just tilt the probe ever so slightly towards the head to visualize the common bile duct. Sometimes you can see it in exactly the same view. If you just lengthen out the portal vein, you'll see the common bile duct draped over the artery, but often you might need to just, tilt the probe up and down ever so slightly. So we're tilting each way just a little bit. So starting from midline, let's look at what those pictures look like. So when I'm in the midline, we've got aorta. I have my probe marker pointing to the patient's head. And I follow the costal margin laterally until I see IVC. If I get to kidney, I've gone too far. We're now into the substance of the liver. So then I need to come back towards the midline until I see where the portal vein here is just entering the liver. And you can see just at this point, the bile duct sitting over the top. But I can then lengthen out the portal vein. And then again, this tiny, this is a super normal one, this tiny, tiny bile duct over the top. So to lengthen out the portal vein, I'm holding the probe marker still and pivoting around so that the non-probe marker side rotates until that portal vein is lengthened out. You can pop the colour on. I know for my ultrasound exams way back in the day, I used to always put the colour on and check the colour should be seen in the portal vein, but a hepatic and hepatic artery, but colour shouldn't be seen in the bile duct. So we used to always just pop the colour on and check, and we're about to go into the exam, and they said if you put the colour on when you're looking at the portal vein, she'll fail you because you've got to find it by landmarks only. So I got super worried about it then, and I'm sure I buggered it up, but I've always been really paranoid about it now to try to find it by landmarks, and then, you know, if in doubt, pop the colour on just to confirm. So we've got some videos. If we focus here on the portal vein, and as we rotate to lengthen it out, you can see the bile duct coming over the top here. Coming over again, we see where the portal vein comes out of the liver and the bile duct draping across the top. So this is where the cine loop button would be really good. We can come back a little bit. And that's all we do with the cine loop as well, is just try to find where we see the bile duct as good as possible. Now, and on this one, we've got a bit of bowel gas in the road. That can always be a challenge. And sometimes it completely gets in the road. The other thing that can get in the road is stones in the neck of the gallbladder. So if I just loop this one again, I've come out, we're into the liver now, tilt, sweep back out towards the midline, to the extrahepatic portion of the portal vein, and then we can see the bile duct draped over the top. This one is just quiet respiration, and during that respiratory cycle, you can kind of track this bile duct along its length and see it away along the entire length, rather than, because I haven't necessarily got it all in one view, but during the course of that respiratory cycle, you can actually track it pretty much the whole way along over to the pancreas and see that it's clear. And so my next victim had to go on the bed. Now, the first one is my daughter, 14, perfect physique. The next one here is Mike. Now, he's not too bad in as far as the physique. He's not your, you know, classic patient overweight and really struggling. But I tell you what, he has a really difficult bile duct. It's absolutely normal. Now, the first thing I was looking up here, he's got quite a long sort of neck of the gallbladder, and then we come back over to find the porter, and it's not so easy on Mike, and he looks like he should be easy. So in this one, we are kind of just seeing a little bit of it here. It's very, very skinny, but his the bowel gas just here is also getting in the road. If you have, and the thing with that is, even though this was really quite challenging on Mike, it didn't matter if we rolled him on his side or not. I think the key thing to think about here is when you have a completely normal bile duct, they are difficult to see, even on the normal people. So if I've had a good look around about where the neck of the gallbladder is and where that portal vein is, and I can't see any other structures, then I can probably assume that it's normal. Because in the cases where it is dilated, it's really much, much easier to see, and it stands out a whole lot more. So we can see it a little bit in parts here. I've gone, you know, I tried intercostal, and that's about as good as it gets on Mike. He's not a big guy, so it was a little disappointing, I must say, that I had so much trouble finding his bile duct, but you know, that's the way the cookie crumbles sometimes. Now, the question also was, where do I put my calipers? How do I measure it? Now, you're wanting to measure the lumen of the bile duct. Your reference point is the hepatic artery, and on Mike's scan there, and even Anya, to be honest, their hepatic artery is so small, it's really hard to see. So you measure the lumen, the crosshair goes right on the edge and right on the edge, so that we get the diameter of the bile duct here, and it's immediately distal to the hepatic artery. So you can see when it's abnormal, it's really dilated, and you get like this double barrel shotgun almost. It's dilated, much, much easier to see. So here we've got a couple of normal ones. Here we've got this tiny bit here. It's probably a little bit intrahepatic, but it's really tricky to find where that hepatic artery was. This one you can see a little bit more, completely thin. I didn't even put the calipers on because the calipers would have just obscured where to put, where you could see it. You know that it's really, really thin though. So up the top we have those normal examples, and here's another one. Whereas this one here is portal vein, hepatic artery, and the bile duct looks bigger than the portal vein. This one was to remind me, if you see a gallbladder that's full of little stones, if they've got a big whopping stone, it just doesn't fit through the cystic duct. But if you see a gallbladder that's full of little baby stones, they're the ones that you need to be really looking at and try very hard to visualize the common bile duct along its length. Because the smaller those stones are, the more likely they are that they can fit down the tubes and be passed. And so these are the sort that we do if we're going to see bile duct dilatation. They're the sort that we will often see it on. You can see again, this is the portal vein. It's just out of view a little bit, portal vein. We've got hepatic artery, and we would measure just here. Here's another one, lots of little stones. Now, if I had found this in clinical practice, the internet's a good place to find these pictures, but it's not very often that you actually get to see a stone in the duct. So anyone who's watching that you find a stone in the duct, feel free to send me the pictures, because it's always good to have some pictures in the library for a start, but you just don't get so much opportunity to see them. We're always looking for them, but you know, it feels like you're winning the jackpot a little bit when you do see one. Not so much for the patient, I guess. Now, the other thing that you need to look at, if the biliary system is dilated, you often will see the intrahepatic ducts dilated here too. So you can see this looks a bit double barrel shotgun out here as well. Now, you may see a stone, but the other thing that can cause this kind of appearance is, for example, a mass in the head of the pancreas that's obstructing the bile duct. So, you know, painless jaundice and sign like this, and if you may not see the mass in the head of the pancreas, but if you can't exclude a stone in the duct, maybe, you know, it's a mass in the head of the pancreas that's causing the intrahepatic duct dilatation. Here's another one. We've got portal vein, hepatic artery is a bit more obvious. Here's the bile duct coming across. It doesn't look particularly dilated, but then you've got this echogenic area, and the giveaway here is more the shadow that comes behind it, because it could almost look like in this instance that you've just caught the edge of the bile duct, but that shadow gives it away that there's actually a stone in the duct. So, does anyone have any questions?
Sue-Ann, that was amazing. I do have a question. It all starts with looking for that portal vein, by the sound of it. Is it always really big and chunky and easy to find, like on your images?
The portal vein usually is, because it's the hepatic artery, no, but the portal vein usually is. If you remember that the portal vein is kind of acting like an artery. It supplies the liver with 70% of the blood flow, because it's draining the gut, and the main supply, or the main job of the liver, is to filter all the crap out of what we eat and drink. And so in this instance, you'll notice the walls of the portal vein are really quite echogenic, which is quite uncharacteristic for a normal vein. Usually artery walls are echogenic and venous walls are very thin and not so echogenic in comparison. But the portal vein kind of acts like an artery, because 70% of the blood supply from the gut is going in via the portal vein. So it's quite a big vessel. The hepatic artery is tiny, but it's given you the other 30%, which supplies the blood to the cells to be able to do their filtration job. So the hepatic artery is much smaller, but the portal vein, acting like an artery almost, bright echogenic walls, and a normal measurement, I think, is 13 mils or something. So you can usually see the portal vein quite easily.
Awesome. Is there anything that it might be mistaken for? So any mimics that I might
vein
get,
or the
the portal vein. So I'm looking for the portal vein, and I think I've found it, but actually I'm looking at something else.
I think, look, I have seen some people kind of mistake it for the IVC. So again, just be mindful, because your IVC is just down here. Be mindful of where things are at. Certainly when I scanned Mike at first, he had a kind of long neck of his gallbladder, and I thought that originally was the portal vein until I saw something deeper. So, but once I rotated and found where the gallbladder was, I could then, you know, orientate myself that portal vein is deeper in the patient, and that one was portal vein versus the, if I show you that picture actually, hang on. I need to just share it. I'll show you what I mean, because, you know, the first glance, that's what I had seen. Can you see my screen now?
Yes.
Yeah, let me go back and find. I'll play some of these. So that's, yeah. This one. So see here, that's what I thought was at first, as it comes up, that's what I thought at first was the portal vein. But then as you scan around, you can see that that's tracking up towards the surface and is and superficially, and is clearly, you know, linked to the gallbladder. And we then see this bit of bowel, and deep to that is the portal vein, just over here.
Brilliant. Okay. And can I spare one last question, which is, absolutely. I know that there's a lot of pitfalls when we measure IVC and aorta. You know, if you measure longitudinally, you might underestimate an aneurysm, for example. Yep. Do we need to measure the common bile duct in transverse as well as longitudinal, or is longitudinal adequate? No,
just in that long picture. I've never measured it in transverse. And to be honest, when it's really dilated, it stands out, and you're kind of drawn to it. When it's really small like this, you're kind of looking and trying to find it. But the dilated ones, we're just measuring it in the longitudinal. I think if in the transverse, you've got to make sure that you're not mistaking it, and which is why you put the colour box on, making sure that you're not measuring the hepatic artery instead of the bile duct. But I've always measured it in long. Have any of, I noticed, is that Catherine Smith on the call?
Celine, how are you?
Jenny, have you ever measured it in any other way?
No, look, it's mainly always in longitudinal, and you know, the more advanced measurement is sometimes the transverse at the level of the head of pancreas, but that's, I mean, you only ever see that view in 5 or 10% of patients anyway, so I don't think it's really a POCUS application. I think it's a sonographer application, so I would stick to the longitudinal. Yeah.
Actually, that's a good point you raised, Jenny. When we first started teaching gallbladder, my kind of method behind the madness was, yeah, let's show you how to do a measurement of bile duct, because you're going to ask. But I personally don't think that this is a point of care application. I know it's there in the CCPU guidelines, but it's actually really quite difficult to do. And especially in some of your patients who are obese and, you know, they can't hold their breath for you and they can't help. Learning how to measure the bile duct is one of the trickiest things we do in the abdomen. And it takes lots and lots of practice. And I personally, I don't think it's a point of care application at all. Certainly not the distal end. You barely ever see them anyway, and only if there's something going on, really. But it's a tricky. It's not an easy. I mean, don't be disheartened if you can't get this on everyone. It's have a go, I guess. But it's not the easiest of measurements to get or views to get.
So, Anne, I'm glad you said that. This is Brian here, because it took me a long time to kind of get comfortable at looking at the common bile duct, so that makes me feel better. A really quick question, though, about patient positioning. I think you had mentioned that you like to have your patients on the left lateral decubitus position. Yep. Is that kind of how you start off all of your biliary and common bile duct measurements? You just cut to the chase, have the patient on the left lateral decubitus, or you start off supine?
I personally, and this will vary from sonographer to sonographer, I always start my gallbladder exam supine. You get absolutely rubbish views most of the time. On the occasional person, you might see things all right. But I always start supine and then see how well I can visualize it before I roll them on the side. Because if there's a stone and it's sitting in the neck, and they roll on the side, sometimes all you need to do is roll them on the side and that stone will move out of the road and you can see that the stone is mobile and clear the neck of gallbladder. For patients who, you know, have trouble standing up and stuff, that might then be just enough that I've excluded a stone that's impacted in the neck of the gallbladder. But if I haven't managed to see very well and I've only seen it, you know, for the best pictures, I'd only take the pictures once they're in the lateral decubitus position. The rolling is just about me getting stones out of the neck. And then if I can't see anything supine, well, I start lateral decubitus and then I stand them up erect to make sure that those stones are mobile and do move out. For bile duct, I just go straight to the lateral decubitus position.
And hopefully, well, my last question anyway. I know that you said you measure the common bile duct just distal to the hepatic artery, but when I've reviewed some formal studies, is a formal study protocol measuring multiple measurements of the common bile duct? I've seen it measured before where they'll say this is the distal duct, this is the proximal duct, and there's
yeah, look, if we're going nuts and that's the specific question, I'd measure it here at hepatic artery and then as far distally as I can see it. I'm trying to see that bile duct go all the way into the pancreatic head. You don't see it in as many patients as you'd like to. So yeah, I've commonly measured it in a radiology setting, I have to say, at the proximal part here and then just as far distally as I can see it.
And Sue-Ann, one view that's often useful too is to, if you can't roll the patient, is to start from a fast view and look between ribs as well.
Yeah. That intercostal view can be helpful, but and again, like I keep harping on about this, you can't just pull out these extra views to assess things on the difficult patient that you can't get a good window on. You kind of have to practice those views all the time and practice them on some really easy normal people first to be able to rely on your technique to pull it out when you really need it. So, you know, practice scanning subcostally, but also have a crack at an intercostal view quite often too, so that you know that you can have confidence in your technique when you need it.
It's funny you say that, because it seems to me like a lot of the emergency POCUS practitioners like looking intercostal because they're so used to doing fast exams. And they just sort of sweep anteriorly and find the gallbladder and I say, oh, you really should be subcostally looking too.
Yeah, well, it's you have to just get things done in a hurry. So you have to do what you have to do. All right. Any other questions there, Jono?
No, that's amazing. Thank you so much, Sue-Ann.
Cool. Well, we might move on to a step-by-step guide to image review. I just wanted to talk through, you know, how do I go about, we do a lot of image review for people, well, it used to count for the CCPU, it doesn't anymore, but we used to be able to mentor people. Well, we can still mentor people, but it just won't tick the box for CCPU purposes. But we have done quite a lot of image review for different people. And I tend to, in the early days, I want to see some video clips so that I know that they're actually scanning and not just plonking the probe at the first spot and happening upon a good picture. So we want to see that they're actually scanning through the area. So, you know, short video loops, 4 to 6 seconds helps. But also just, you know, how do we go about it? What are the sort of criteria that I'm looking at? How do I systematically evaluate their images? I dare say some of the people on this call are probably evaluating some of the people in your department. So I thought that it would be a good opportunity to talk you through the method to my madness. So when I'm looking at the image review, first question I want to sort of get across is, have we done an appropriate investigation? Are the images diagnostic? Have you accurately interpreted the images? And then, you know, far be it for me to say, but have you acted on those images in the correct way and managed the patient? And have you accurately recorded the images? Now, it's useful to keep in mind that it's very easy in an ultrasound exam to take a series of pictures that don't necessarily tell the story of what you found on the day. You can take a picture and be in a hurry, and you know, you go back and look at them later and go, oh geez, is that an artifact or is that a stone, or what is that? So it's important to kind of think about the fact that your images should tell the story that you've seen and should match up with the story that you're reporting. If you've got a Australian image in there somewhere that sort of suggests a different differential, then you're kind of undermining your study. So the other thing that we do for anyone who is having image review with us and that we're mentoring is we give them an example of an exemplar. And these are really handy so that people know what to expect. So this is a series of pictures in an ideal patient that have been documented with appropriate depth and gain settings and stuff like that. If we could possibly get as close to perfect as we can, this is what a perfect exam looks like. Now, in clinical practice, very rarely do you get the opportunity to perform a perfect exam for lots of different reasons. Potentially, you know, you don't have, you can't get one of these views. Now, the thing about that is, let's say, for example, on this particular patient, I really couldn't get an apical 4 view. I still want people to take an image there to show that they've actually, and document that they've actually looked, because then you can comment and say apical 4 chamber view suboptimal. But if you haven't actually taken a picture and sort of left tracks that you've been there and had a look, potentially someone could come back at you and say, well, you've actually done an incomplete study. Why didn't you have a look at the apical 4? That's the best view for that particular pathology, and you haven't done that. So does that mean your knowledge is lacking? Or, you know, it might in fact be that on the day you couldn't get a good window, but unless you've documented it somehow, either an image that showed that it was rubbish, or you've noted in your reporting of the study that you couldn't get that window, for all intent and purposes, it just never happened. So, you know, here's a minimum image series. You can very quickly at a glance, they can look back and go, well, they're the views that I need to take as a minimum set for a start. And also that's what it should look like. So I can then, you know, the learner can compare their pictures against near perfect ones to say, well, how am I doing? And they can start to assess the images for themselves as well. So I find that the exemplar is really helpful, because often people just don't even know what pictures to take. And if you've got a standard set of pictures, it helps you carry out a very systematic approach to your scan, whatever it might be. So the next question I'll ask is, what question were you asking? Why did you do this point of care study? What question were you asking, and what did you expect the answer to be? Because an ultrasound or a point of care exam should be used to answer binary questions. If they're asking the wrong question and performing the wrong test, then it might be out of scope and not appropriate to be performing that exam in an emergency context. So by having a clear idea at the beginning, what question is it that you are asking, and what did you expect the answer to be based on your clinical judgment, you're keeping the focus on a point of care examination with binary questions. I've always sort of spoken about a point of care study. If it doesn't have a yes or no answer, it's not a point of care study. You should be sending it for a formal exam. And about the only exception to that is how many weeks in first trimester pregnancy, and that's for obs and gynae more than point of care studies anyway. So by asking those questions, I can determine, is the examination appropriate? Is the exam within scope? Are they actually asking the right questions that can be answered with the point of care exam? And are those questions, do they have a yes or no answer? The next thing we do is then have a look at the image itself. Now, the first thing, I don't get to the actual picture just yet. I'm having a look across the top of the monitor to identify the, you know, what date and stuff was the exam performed. Did you have the right preset? And that's usually up in the top corner here. Did you have the right preset and the right probe for the job? Looking at the patient details, have you entered the patient details? Have you put your user or your user details in the patient data form? Have you chosen the right probe? Have you got the right preset? Then we go down the side of the picture, and this is where we can see the imaging sort of parameters. What frequency was set? Did you have, for example, for a lung ultrasound exam, was tissue harmonics on and compound imaging on, or have you in fact turned them off? We can look at things like dynamic range and then some of these other things with tissue specific index and the thermal index and things like that. You can, if you know what they're supposed to be, you can evaluate that as well. Looking at the frequency, what technological factors are on, like the multi-beam or the tissue harmonics. Then we get into the image proper, and I'm looking at the frequency setting. Is it correct for to actually see the image? Can I see all the way through to the deeper part of the image? Now, the first step is making sure there's enough penetration with the right frequency settings, making sure that the depth is set appropriately. And remember, most of the modern point of care equipment has a dynamic receive focusing. So the focus is set according to what depth you have, and it'll focus at several zones in that depth. So if you've got your depth set in correctly, potentially your focal zone is at the wrong spot. So you don't necessarily, on a lot of the newer systems, you don't necessarily get a chance to tweak it and move it yourself, which is probably a good thing. It narrows it down that you have to have the depth settings set correctly to make sure that the focus is at the right level. Now, this is on a GE system where you can manually adjust the focus. So I can look here to see that it's at the back of the liver and kidneys. And last but not least, to have a look at the gain. Have we got an even shade of grey across the screen, which will indicate to me whether the time gain compensation is set correctly? Or is there, as you can see in this instance, it's quite dark in that near field. So I don't know what's going on here, but I really want to crank up the near field gain to make sure that that's not something going on. So the gain across the whole image, and then what's happening, is it too bright or is it too dark just overall? If you've got your gain set too dark, you're missing information. If you've got your gain set too bright, you're writing echoes in that just don't exist and can give you artifacts. So now, after we've kind of looked at those things as a brief glance around the edge and having a look at that picture, now we get to the diagnostics bit. And the philosophy behind this is, if you haven't got a good image, you can't possibly get a good diagnosis out of that. If your image, like this one, is really dark in that near field, I can't be sure whether that might be, you know, is that a splenic injury or something, or a liver injury? I don't even know if this is left or right, so it could be either. Is that pathology or is that a gain setting? So that's when you start to see, when you start to look and say, well, is this diagnostic? If you haven't got your imaging parameters set well, then you're not going to come up with the right diagnosis. If your gain is set too bright, you potentially write echoes in and obliterate an area of free fluid. So, you know, those imaging parameters are important to kind of take a backward step and then come forwards again to look and say, well, with the question that we had in mind, does this picture let me answer that question? So we're looking now, have we seen the anatomy that we need to see? Is the picture in fact diagnostic? Does it answer the question? And does it work for the management? How do you integrate it with your patient management? After I've done that for each picture, then we get on to the measurement technique, which depending on the examination that you're performing, you're just looking to make sure that it's accurate, that the measurements are taken in the correct planes, because the reference values are all very much defined by what the right plane is. So for example, the common bile duct we're measuring just after the hepatic artery. Well, it's good to be able to see the hepatic artery to have that reference point. The crown rump length here, we want a sagittal picture and we want to measure in the midline. So, you know, are we in the right position in the first place to take the measurement, and then where are the calipers placed? Are they accurately positioned? Now, just one quick word on annotation. You know, as sonographers, we write little mini essays on the side of the film. It's right kidney, upper pole to lower pole, right kidney, sup to inf, in trans. And we write these essays. I think in the context of a point of care exam, if you put an R and an L for right and left, B for bladder or pelvis, whatever you're looking at, H for heart, you're doing great. But it's really important to determine right from left. So these images that we're looking at of the liver here before, I'm assuming it's liver, it might in fact be spleen. There's nothing here to indicate is that the right side or the left side. Now, I personally have had a fast scan. The doctor got the answer right. I managed to get to say thank you to her at the conference in Tasmania last year, Brian. But, and she remembered my case, but probably because there was a sonographer watching her, I think she was really quite nervous about it. But also too, I asked her for the pictures after it. Now, the point about this is that she got the answer right, and I got the treatment that I needed in a very timely manner, thankfully. But I looked at the pictures and they were garbage. They really were not very good pictures at all. I couldn't tell if it was a right upper quadrant or a left upper quadrant or even the bladder. So a lot of them were overgained, but we couldn't tell liver from spleen, and there was fluid everywhere. So that didn't help either. So just some very, very simple annotation is going to be able to help you, should you need to down the track. You know, you've been questioned on the results you got or how you integrated those findings into clinical management, and someone wants to challenge you in court, chances are you're not going to remember that particular patient. And, you know, that legal action might come 12 months, 18 months after when you did the scan. So if you can't look at your pictures and have a quick glance at them and easily recognize yourself, where the heck you were, then you're in the shtuck. So it might be that you always approach the exam right upper quadrant, left upper quadrant, pelvis and heart, and if you do that every single time. But what happens, for instance, if on this particular occasion that you're getting challenged on, you know, someone was doing something on the right side, so you just started the exam and did left side first, and you can't comment where or what. It's also really, really important musculoskeletal to do a comparison picture and note which side is which, because you can't tell for love nor money which side is which on any MSK work. So it doesn't need to be an essay, but something really, really brief that is meaningful for you, so that if someone challenges you 6 months, 6 years down the track on those pictures, you know what you meant. Now we come back to the minimum imaging set again. I then kind of take a step back to look at the examination as a whole. Are there enough pictures? Have we fulfilled the criteria of the minimum imaging set? Now these are the views recommended for the basic echo and life support CCPU unit. And all we've done is take a picture of them and have it as a visual rather than a whole block of text in the back of a long wordy document. So at this point, we're kind of taking a step back to say, as a whole exam, have we told the right story of what's happening on the day? Have we got at least a minimum image set? If there is pathology, go nuts. Just take as many pictures as it needs to be able to document where the pathology is, its size, its echo texture, and its relationship to surrounding organs. So, you know, if the minimum set is 6, then, and you've got some pathology, you might end up with 16. You know, memory space on these machines is pretty cheap these days. So it doesn't matter that you've got, I mean, if it's just the same picture again and again and again, it's a bit silly. But if it's actually documenting different aspects of what you've seen, then, you know, take as many pictures as you need to. So are there enough pictures? Do they tell the right story? Have they been labeled appropriately? Are the images, are the findings recorded accurately and described well? And as I said right at the beginning, I always encourage people, especially in the early days, to take a short loop so that I can see that you're not being a plonker. I love that term of Anthony's. You're not just plonking the probe on and stumbling across the best picture that you could and just taking one picture there instead of thoroughly scanning the organ. So we're then looking at what anatomy, what views, are they diagnostic? We look through the technical parameters, we talk about the positioning, and then how you could improve it. So that when I'm doing a image review, these are the sorts of things that we talk through on the case. Now, just a word on positioning. As an example, there was one of the local docs in Melbourne here had sent me some pictures and said, this bloody gallbladder is full of gallstones. I could tell, but I just couldn't make my pictures show those gallstones nicely. They went for a formal scan, and of course there's absolutely pristine pictures, lots and lots of gallstones. And I reviewed this case and there was pretty much 8 pictures of exactly the same thing. The depth was set incorrectly. The gallbladder wasn't in the middle of the picture, taking the best advantage of the specular reflection from those gallstones. And because they were small gallstones, that was really important. You know, if you've got a big chunk in gallstone, you can kind of hit it from anywhere and it's going to be obvious. But with the little, you know, the sub 5 millimeter gallstones, if you don't hit it spot on 90 degrees, then it's hard to get the shadow coming behind that gallstone. And the other thing that was a problem, because her depth was set incorrectly, the focal zone was at the wrong spot. And anyway, I said to this doc, I said, you know, when you performed your scan, which way was the patient positioned? And she's like, oh, on their back. And I said, what did they do? Because she escorted the patient around to imaging. And they said, oh, they rolled them on their side. And I said, well, there's most of the problem here. And the other thing was take a big breath in. So we can, even just by looking at those pictures, there's some of these tips and tricks that we can give you in the review. Now, I wanted to mention next week, we're going to have Elias Jaffa. He is an emergency physician, or hacker, as he describes himself. He's a co-founder of Global POCUS. Now, he's going to talk to us. He's created this little gadget that can help with tele-POCUS, if you like. And so, you know, in this age of COVID, and we, you know, might not be able to do the teaching in the manner that we're used to, what are some of the technology things that you can use to help your teaching? So Elias will be joining us for a bit. Well, cool. We might wrap it up there. Thank you for joining us on the line. If you have any questions for next week, please send them in, Twitter, email, whatever method suits you. And before we go, I'm just going to once again say thanks to the team at Philips for supporting this venture and providing us with an opportunity to chat POCUS and, you know, be ultrasound lovers. So hopefully we see you on the call next week.